welcome, Samuel. We are really delighted to have Dr. Berlinski with us, who is working at the IDB and is also a member of the Lustig project. And he and his colleagues worked on a very interesting paper on health inequalities, which is his area of expertise. So I think we will have now a complement to what we had last week, which focused on education inequalities with Miguel Sekeli. This is another one of the dimensions in the multidimensional analysis of inequalities that is very important, health, of course. So, Samuel, the floor is yours. And as always, we invite the speaker to share a little bit about themselves with the students, which is always interesting to know about people's careers, how they get to where they are, what happened, why did they decide to do what they do, and so on. Thank you very much again for joining us.
Thank you, Nora and Ludovico, for the invitation, and it's a pleasure to be here with you today and to have been invited to work on the Lustig project, which I think it has produced a very interesting body of knowledge regarding inequality in Latin America. I'm going to talk to you about health inequalities today. I have to say that the first thing that I did in research in my life was on health. I was an undergraduate student in Argentina, and they have some scholarships to do research for undergraduate students, and I applied for one of them, and I started working on health and health economics with the sponsorship of the late Alfredo Canavese at that time. And then I went to grad school in the UK, and I did my academic career, but haven't worked a lot in health. Mostly I work in education. And so I have a first stint of academia in the UK, and eventually moved to the IDB. And at some point, I work at the research department of the IDB, and no one was working on health in our group. So I started working on health again. And as hopefully you are going to see from my presentation, I think that is, as a development economist, someone who is interested in development, this is a really nice area to work, because I think there is a lot of potential to improve in terms of the outcome of the population in Latin America and in developing countries in general. So that's a brief introduction of how I, became a health economist.
Yeah, you were a professor at UCL, right?
Yeah. So my first stint was in academia as an assistant professor at UCL, and then eventually we moved to DC and to the research department of the bank, where I've been for now 15 years, quite a long time. And eventually, in that road, we realized that someone had to do some stuff on health. So I went back to my health roots and started working with Marcos, which I knew from UCL, Marcos Vera. And the work I'm going to show you today is a collaboration between Antonella Bancalari, Marcos Vera Hernandez, Maria Fernanda, and I'm losing her, forgetting her name, Dolores de la Mata, and Dolores de la Mata and Giancarlo Buitrago. So, big team, because it's many countries, it requires quite a bit of expertise in the different countries. And I think that also what makes this project particularly interesting. And the good thing is that we made a group, and we are working on other projects after that, because we enjoy working on this. So this is a very nice externality of this network. So can I share my presentation here?
Yes, please do.
Okay. So there you go. Can you see?
We can, yes.
Okay. Let me probably move it to the other screen so I am not looking at the, at a different, I look at the same place where I am presenting, okay. So I think that a good place to start this
Samuel,
presentation.
we can no longer see your presentation.
Okay.
We see your screensaver.
Okay, let me just go back to this. No. Um, can you see now?
Yes.
Okay, sorry. So, I think that a nice place to start this presentation is with a little bit of a motivation of why health is an interesting outcome to study beyond the obvious reason, as an important measure of well-being. Although, we haven't observed a lot of catch up in terms of income per capita between rich and poor countries. We observe an incredible catch up in terms of life expectancy between rich and poor countries. So somehow, poorer countries have been able to get closer to the life expectancy in richer countries and achieve really, really important health gains in the last 30 or 50 years. An example that I love to give is that of Peru, where, among children from indigenous mother, mortality fell from around 100 per 1,000 live birth in 1991 to only 25 by 2008. Just to put this number into some sort of comparison, it took the US from 1935 to 1985 to achieve the same gains for African American children. So the region has made massive gains in terms of improving health and reducing infant mortality. And as I said, this is an area where we are able to catch up with the richest countries. So it just motivates me to work in this important topic, and hopefully will motivate some other of the students that are here at the course. Please interrupt me at any point if you have questions about what I'm saying. So just to give you an overview of what I'm talking about, so in case you get somewhat lost, I am going to start describing the epidemiological profile in Latin America and the Caribbean, and then I will take you through the different inequalities in the health domain over the life cycle. I will start with maternal and child health, then move to mainly reproductive health, and then discuss non-communicable disease, including mental health. When we are going to talk about the dimension of inequality, I'm going to focus on the slides that you're going to see on socioeconomic status, but I will briefly refer to urban-rural differences and gender difference. Okay, if I have time, I think this is the only team that have a combo of 2 papers, and we have a paper on health systems as well. And this is an important, of course, source of potential inequality in health outcome. And I'm just going to hope to have time to briefly say something about that. Okay, I will finish with some policy implications. So that's kind of the roadmap of what's going to happen. So let me start then with describing the epidemiological profile in the region. So this is a graph of disability adjusted life years in 1990. So you see the light blue is the percent of the years lost to non-communicable disease. The kind of pinkish one is for communicable disease and maternal diseases, and the last one is due to injuries. As you can see, a large share of the burden of disease in Latin America was due to communicable disease and injuries. And that was true also of most of the developing world. If we zoom now into 2019, what you can see is that the blue is overtaking most of the graph. So most of the disability-adjusted years of life that are lost are due to non-communicable disease, while communicable disease is a relatively small share. And injuries remains more or less constant. The story that I'm going to tell you today is that, basically most of the inequality lies in communicable disease that still the poor are facing, and the rich not so much. And as regards non-communicable disease, there is some inequality, but it's not so marked, okay? So just for us to be all on the same page, I mean, when I'm talking about non-communicable disease, I'm usually thinking about cardiovascular disease, cancers, and other disease that can be prevented in part with changes in lifestyle, such as diet and exercise. Non-communicable disease and maternal disease, are rather obvious, okay? And injuries include road accidents and suicides, okay? Just to give you an idea of the sort of diseases I'm talking about. So this is just to show you that what we observe in terms of the change of the burden of disease, the increase to non-communicable diseases, of course, are mere associations. As the countries in the region, are the share of the non-communicable disease is associated with having a population that is older, which having countries that are relatively richer, okay? It seems not to be associated with the gene of the country, so it's not a feature of more or less unequal countries that they have a larger share of non-communicable disease. There is an association with health expenditure, which is probably also driven by the GDP per capita and by the fact that, when your population is getting older, you start spending more also on health, okay? So that just gives you a picture of the overall disease environment and some sort of cross-country possibly inequality in terms of this disease, given that if you think about Latin America, which is a large continent, there is a lot of variability in terms of the distribution of age. Some countries are relatively younger, some countries are relatively older, to put it somehow, okay? So how we study inequality in this set of studies? Well, we use household surveys. I don't know if you came across this in other presentations, or if you guys are going to do any research, any applied research, you will come across the demographic and health surveys, which were run in a lot of developing countries and sponsored by the US. Then there are the multiple indicator cluster surveys that are kind of similar to the demographic and health surveys, but they have some wider, they reach some relatively richer countries that are sponsored by UNICEF, who runs some surveys for adults, which are the STEP surveys. Who doesn't run them? The health ministries of the different countries run them, but who sets the standard and the type of questions that are asked, or that there can be more or less harmonized between countries. And then each countries may or may not have national health surveys. One thing that we came across in doing this is that there are not, very harmonized way of measuring health outcomes across countries, which makes the enterprise of comparing the countries kind of sort of difficult. But we do the best we can. It's easier for younger populations because the demographic and health surveys and the mix are in very many countries. Okay, it's harder in adult life, and we use simple techniques, and this is what you are going to see here. And you can see them in the paper if you are interested in seeing what are the differences that are statistically significant and stuff like that. Okay, but I'm going to show you mostly equiplots and some ratios at different points of the distribution of income. Okay, so let me start then, with the life cycle presentation of access to health. So when before you are born, how much access do mothers have to antenatal visits? To at least, this is a graph for at least 4 antenatal visits, and as you can see, the average for Latin America is around 90%. Almost everybody has access to 4 antenatal visits. And in very few countries, there are large inequalities in terms of access. They are the most noticeable cases, the one in Bolivia at the top, where you see that the highest, that are the darkest circle, have a lot, so that they are in the top wealth quintile, okay, have a lot more access than those are in the lowest wealth quintile, that is the light blue, okay? And in the paper, you can see we do them with education, and the patterns are similar. So Bolivia, Guatemala, Haiti, you see the largest difference in terms of access to quality antenatal, to at least 4 visits of antenatal care. You will see in the paper also quality of this antenatal care, which shows similar sort of patterns. So this explains.
Samuel,
Yeah,
I think
sure.
people would benefit if you describe how these graphs are constructed and should be interpreted.
Sure, this is what I'm saying. So it's very simple. Each dot, okay, so we have, for example, so this measure is if you have 4 or more antenatal visits, okay? So, and then we have a measure of wealth, which usually is constructed based on assets that are available at home, okay? So we divide the population on 5 buckets based on their wealth, and then for each of these buckets we measure on average whether it's an indicator variable that takes the value of 1 if you had 4 antenatal visit, or 0 otherwise. So if you have, so for the lowest, so if you look at the case of Bolivia, for example, the lowest wealth quintile, only about 25% or 27% had at least 4 antenatal visits. And for the highest income wealth quintile, which is the darker black circle, around 90%, more than 90% had at least 4 antenatal visits. And if you look at in the y-axis, you have the name of the countries, and when you see 3 stars, is that the differences are statistically significant between the quantiles. Is that clear? Yep, and these are called equiplots, and all of the equiplots I'm going to show you have the same sort of they are made the same way. So this is when we talk to antenatal care, there's been some improvement, and that's is basically shown in the way that infant mortality has fallen in the region. The region is doing much better in terms of that. Okay. Now, once the kids are born, we have some standard measures of their well-being, infant mortality, stunting, and obesity. And well, the first thing one of the things we learned during this project is that there is a double burden of disease for the children in Latin America. First one is stunting. So stunting is measured as in the following way. You have the height of the child for their age, and then you standardize it. And you standardize it at, with a normal distribution. So if you have a value of less than 2 on that score, you are considered stunting, which is basically to say, in a very pedestrian way, you are too short for your age. And this is usually taken as a measure of poor nutrition, a pure environmental context in terms of there is lead, or there is, well, in countries where there is lead painting, like in the US, you will see that it has an effect on that, or the quality of the of water that people have access to, so because there is diarrhea. So there is a sort of other contextual factors, not only diet, that determine whether a person whether a child will be stunted or not. And as you can see in this graph, there is a red dotted line, which is our benchmark, which is the OECD benchmark, the OECD without including any LAC countries, which is around 5% of kids are below this 2%. And in Latin America, this is around 15% of kids. So 15% of our kids are stunted. Okay, so there are less than 2 standard deviation of the height they should be on average by their age, because this is standardized by age. And then you can see that not only there is more stunting than on the average OECD country, there is a huge dispersion based on wealth. So here, the reverse of the other graph that you just saw, you see that in a country like Guatemala, which is well known for having a huge poverty, a huge inequality in children outcomes, you will see that for the highest quintile, stunting will be around, 18% of kids. And for the lowest quintile is larger than 60%, almost 70%, okay? And this, the order of the dots is really, it makes sense in the sense, okay? In some way, it follows what you would expect. There is a clear gradient on wealth.
One question, I mean, there's
Sure.
no data here for Argentina, Brazil, and Uruguay.
No, because this is mostly DHS data.
Hmm.
So there are some standards for height and weight, and some for taking anthropometric measures, and this is somewhat expensive to do. So here, this is all data from DHS, where as I say, was funded by the US. This measurement. I'm sure that in the I don't remember whether we have whether in the National Health Service of Argentina there are representative samples. But if you take countries like so here the more the richer countries of Latin America, like Chile, is not here, and is relatively the benchmark is very similar to the OECD. So there are countries in the region that have achieved, that have eliminated stunting, or they are at the OECD level. I mean, there's no excess stunting.
Yeah. So, but so you don't have data for this variable, but you have it for others. For the cases of, I mean, to capture Brazil, inequality in health must be pretty high, I presume. Not so
Yeah.
much in Argentina. Then, my second question is, I always wonder when people use OECD as benchmark, because Mexico is part of the OECD, and so is Colombia.
No, this is without the Latin American countries, the benchmark. So yeah. So now this is overweight, which is the kids are short, but at the same time, the patterns of feeding and exercise are not that good. I mean, the Latin America is at the OECD average. They are used here. You see the reverse pattern. So among the richest kids, you see higher levels of overweight than among the poorer kids. This is most likely driven by income and access to food. But this is what I was saying, that there is a double burden of disease in the region, in the sense that the nutritional environment of the poor is such that they are stunted, and at the same time the rich are over consuming probably and on foods that are not good for their kids. And we know that these things have long-term consequences. It's not something that they grow out of this easily. In terms of, I don't have graphs here. There are in the paper. In terms of the rural-urban pattern of this, there are, as you will expect, I mean, there is more stunting in rural areas. There is more overweight in urban areas. My recollection is that between boys and girls, there is no much difference, at least in these statistics at this age. So what we see is that at the beginning of life, there is quite a bit of inequality between kids, despite the fact that access to healthcare during pregnancy seems to be reasonably reasonable in many areas. Then we move further into what is teenage pregnancy, and which is one of the most appalling measures for the region. The region has a rate of teenage pregnancy which is of every 1,000 births, I think that 60 are by a teenage mother, and this is the second largest in the world. The first one is the Sub-Saharan Africa, and it has been pretty stable over time, despite the fact that fertility rates have fallen dramatically in Latin America. So I'm just saying, just to put it in a different way, we are having the same number of kids that we had 20, 30 years ago, but we still have, we're having a lot less kids than we had 20 or 30 years ago, but we're still having about 40% of women have their first kid before age 19. So let me explain this figure carefully, okay? So here we take all the women at age 25, and we see retrospectively whether their first born alive or not was by age before age 19, okay? And, you know, again, we have the wealth quintiles of the time, and we have the education of now, okay, of age 25, and we have when we have the education is age 25, you can, you know, there is no causality here. This is just descriptive. You can think that these things go into, you know, there are issues with that, okay, because if you were in school, if you became pregnant when you were in school, you might have dropped out school, etc. But, you know, that said, what we observe is that among the highest, the better educated, the highest wealth, there are lower rates of teenage pregnancy, and the highest rates of teenage pregnancy are among the least affluent in the society. And as I said, from a very high level, so 40% of these 25-year-olds on average have had their first kid before age 20. So if you think about the consequence of that for education, or for, you know, entering the labor market, etc., they are dramatic. We, interestingly enough, we have some evidence in the paper, and it's, at least in terms of descriptive terms, it seems that you know, people have access to some birth control methods, and people are cognizant of different ways of controlling the reproductive part of their health. However, it seems that, you know, there are still a lot of pregnancies early in life. There are, you know, programs that have been successful at reducing this, such as long-term contraceptives that are put on the arm, etc. These have, you know, they have been used in Latin America, they have been used in Africa with relative success. Still, you know, we still have this very high rates of teenage pregnancy and this very high inequality of teenage pregnancy. So I think that this is, you know, fundamental policy issue. We move from, you know, the what is considered the communicable and nutritional part of disease to the non-communicable. And as I say, among the non-communicable disease, you will have, you know, diabetes, cardiovascular disease, hypertension, and what in the medical literature called neoplasm, that are cancers. And what we observe, so here there is a lot less data. We can only use what we call steps, which are these WHO measurement. And these are, you know, usually in the medical literature, they are considered lifestyle disease. So, you know, these are diseases that are affected by how much exercise, by overweight, by your diet, by whether you smoke or you don't smoke, how much you drink, etc. So we see here, we have here an equiplot of hypertension. And, you know, with the exception of we see in general a pattern, with the exception of Peru, where the richest, where the less affluent have higher rates of hypertension, and the less affluent have, the more affluent have lower rates of hypertension than the less affluent. So hypertension, I'm sure that you know this, they go, so the way the survey goes is they go to your house and they measure your blood pressure and they say, oops, you know, it's too high, okay, it's below the usual boundaries. So you get a, you know, you get a 1 if you have that. There is also information in the survey which is very interesting, where they ask you whether you know that you are hypertense. and you are taking medication for that. And we see also inequality in that measure, as you will imagine. People that are more affluent are more cognizant that they, have high hypertension. As I say, Peru is the only country where this is reversed. We don't have a great explanation for that. Maybe it's the diet. Maybe some environmental factor that we don't understand well. What we observe, okay, is and I'm gonna make that, when I do give you my the key summary statistics of this, is that although there is inequality in non-communicable disease, there is far less inequality in terms of socioeconomic inequality in terms of NCDs. It is important to say that these graphs have men and female together, and women are women are exposed to non-communicable disease and to cardiovascular disease. They have high hypertension like men. They have all the same ailments that men have. They do have heart attacks, and we observe differences by socioeconomic status on this. So there are not. I'm not sure whether we can. I don't remember well, but I'm not sure that we will be able to say much about rural and urban because these surveys are mostly are nationally representative. So the sample of urban population is of rural population is relatively small. So one of the factors, the non-communicable disease that have grown in the last 20, 30 years, and is to blame for the increase in the burden of this non-communicable disease, is mental health. So again, this is hard. There are not many measures across national health across that are comparable across countries, and for many countries we have harmonized 5 of these national health surveys. Okay, and one thing that I should have said before, when I show you the hypertension measure, what happens with this health measure is that they tend to vary a lot with age. So for example, it's well known that mental health is or some of the issues related to mental health are kind of U-shaped, or that hypertension increases with age. So we standardize this to a person of age 60. Okay, so when I say previously, okay, here that 50% of men have hypertension, I mean 50% of men age 60. Okay, 25-year-old do not have hypertension mostly. Is relatively low. The same goes for these graphs on mental health that are standardized to age 60. And what you can see is something that this is with education, the equiplot instead of with health. That this is an indicator variable that takes the value of 1. If someone is considered depressed based on their index that used in their countries, on the mental health survey in that country. And as you can see, it is around 45%, which is a little bit higher than in OECD countries. And you see this gradient on education, which is known from other countries, which is less educated people are more inclined to show depressive symptoms than more educated people. There is a difference that is well known between men and women. Women are more likely to show mental health issues than men, but men are more likely to, to harm themselves, committing suicide, etc., than women. So this distribution of and there is a gradient on education as well on those measures for men and women. But this is something, as I said, that it tends to grow with age. Though, I mean, after the pandemic, etc., these measures might have changed. I should have said that, of course, we haven't said anything about the pandemic. Okay, this is all done, before 2019. The pandemic had effects. It will be interesting to see whether they either reinforce or not some of the patterns that I have shown you until now. So just let me give you a key summary to reinforce the point I have tried to make, which is here you have the education gradient on, on the middle axis, and the wealth gradient, which is basically the ratio comparing the lowest to the highest group. If this is greater than 1, it shows that there's higher prevalence of this indicator in disadvantaged groups. So as you can see, having 4 or more visits of antenatal care, there doesn't seem to be an education and or wealth gradient. Where you start to see these high wealth gradients are in infant mortality, in stunting, and again, you see the reverse gradient that I told you in relation to child overweight. Then you see the teenage pregnancy gradient and wealth gradient again, and then a falling of this gradient when you measure non-communicable diseases in adult life. So that's the main message in terms of those indicators. So these health outcomes, okay, are embedded within a health system, okay, that is an important input on how we get to where to those outcomes that I have shown you. I haven't. Are there questions? People have no clue what I've said, or they understood everything. It was great.
No, the questions will come later. But
Okay.
Before we go into the health systems,
Sure.
the outcomes that you showed are, partly due to health systems, but also partly due to what people call the socioeconomic determinants of health, right?
Of course.
And are we going to see any of sort of an quantitative distinction between the weight, if it's possible, as a causal factor in determining the outcomes? Or even if we don't have a quantitative analysis, I wonder whether you have any opinions based on the work that you guys have been doing.
So I think that we have some sort of explanation when we discuss the health system, where we try to separate what can we explain and not explain based on the factors that we observe in terms of this inequality. So let me just get there in a little bit, because I just want to introduce one ingredient to this inequality in the health system in LAC before I go to that, okay? It will be clear in a second. So these outcomes are embedded into a health system, okay, which has, two key components, okay? The way it is financed and the way the health services are delivered, okay? And this defines what, people call the 3 canonical models of health systems in the, developed world, which is the Beveridge model, where there is basically a single public insurer where which is funded out of taxation. that has nothing to do with your risk of contracting illness or anything. It's just, pure taxation that comes from VAT in the case of the UK, or from, employer-related taxes. But there is a single public insurer, which is the government, and there is free healthcare at the point of consumption. And most of the providers, there is some private providers in the UK now as well, are public. Okay. Then there is what we call the Bismarck model, where instead of being only one fund, there are multiple insurance funds. So this is similarly to the way we do it a lot in the region, and it will come clear in a minute, related to your employment or your, to the type of employment you have. So you have one insurance for people that are in the metal industry. You have insurance for people that are in this company or in this other company. Okay, some of these but instead of being financed by premiums that are related to risk, are basically payroll tax financing. So there is some subsidization between different people with different risk of being sick. But here the provision, okay, you can go to any doctor or any hospital that you see fit, independently of how this is funded. You just belong to this insurance fund, and you can go everywhere and you pay the capital. Okay. Then there is the US, the managed care system, which is a typical US thing, which is an integration of Beverly and Bismarck, meaning that some people are in, of a system that is where there is only some people are in a system where there are collected funds from their employers, and these funds are premium adjusted by risk. Okay, but the difference with the Bismarck model is that usually you have a set of providers that you can visit. You cannot go to any provider that you want. Okay, and the very poor have a very a different system that look more like the Beveridge case. So Latin America has this
Medicaid, right?
Medicaid, yeah. So Latin America has this huge issue, okay, where there are contributory and non-contributory arms. So most of the countries in the region are not in the. There are 3 countries. I'm going to show you a taxonomy in a minute, where have a kind of a Beveridge system. Most of the country are in the middle. They kind of have a Bismarck system, but in some cases, which are the contributory population. So you have formal employment, or you're receiving a pension, which is the consequence of you contributing, and then you are in the contributory system. Okay, and that, you have a set of providers, most likely, and you have a set of rights in terms of what you can receive for your health. And then if you are not in the contributory system because you are informally employed most of the time, or you are unemployed, most people are informally employed and being unemployed, you are part of the kind of a Beveridge model, where your benefits are not so well defined, and therefore and you have access to a separate network of health providers as well. And answering your earlier question, Nora, in the paper we try to look, okay, so how much of the health inequality we observe can be separated between being in a contributory or non-contributory system and these other demographic characteristics of people. Okay, and I'm going to show you this in a second, but we don't find very much, particularly for early in life, but mostly for non-communicable disease, we find that this issue of contributory, non-contributory plays a role in how these outcomes look like, not so much in those early in life. So just to give you a sense of the taxonomy, this is, we do it the best we can because it's not clear cut, but the Brazil, Costa Rica, and Cuba had something that looks like universal coverage. Then countries like Colombia, Mexico, Peru have an explicit, are in the Bismarck system, but if you are in a non-contributory part, there is a program which people that are in non-contributory system belong, and they have defined benefits of what they can get. If you are in a country like Argentina, Ecuador, El Salvador, if you are in the contributory system, you have a formal employment or a formal pension, you are fine in the sense that you have access to this Bismarck type of model. If you are not, you have some sort of implicit coverage. So you go to the public hospital and you get treated, okay? But the benefits that you get are not necessarily well defined. I mean, it's kind of fragmented. So you create programs so that people that are in the non-contributory system have access to some standard benefits, but it's not that you belong to a really explicit insurance scheme like in Colombia.
There is a couple of questions in the Q&A.
Sure. Let me just finish. So Chile and Uruguay are a mix, okay? There is better coverage and people can opt out and upgrade and buy private insurance, etc. Yes, should.
So one is perhaps, similar to my question, is you discuss many economic and behavioral factors influencing health inequalities. Which do you think plays a bigger role in these disparities? And the second one is, does the health system definition include foreign aid, i.e. USAID health promotion programs?
It includes all sorts of programs that may or may not have been received USAID money. I don't have a clear picture in my head. I don't know whether Nora, you know this, but I thought that DHS was funded by USAID. That was my recollection, but I wasn't 100% sure.
I thought so too. I was going to ask you that, but I think
yes, I think that someone can Google it while we speak, but I just turn off all my Googling tools at this point. But I think that DHS was funded by USAID, and there are lots of, as I say, where you have implicit coverage through private providers. There are programs that may have received funds from USAID. I wouldn't be surprised.
Yeah, like in Haiti, maybe in Guatemala, and then the poorest kind of Honduras, maybe not in Argentina or Brazil, maybe.
Yeah.
But for sure in Haiti, there must be lots of programs that involve USAID.
And the answer is yes, it is funded by USAID.
Yeah, DHS.
Yeah.
So what are the key findings that I can tell you in terms of this, in terms of feeding into these inequalities? So the main source of, there are two sorts of inequality, if you want, between this system, being in the contributory and non-contributory system. One is how much you have to pay out of pocket to get what you want, okay? And the other is how good is the quality of care you receive, okay? This is incredibly difficult to measure, okay? But so first we get a crack to see whether there are funding disparities and quality of care. And we observe that the contributory system tend to have, more spending per member, okay, than the non-contributory system, and higher quality of care. In terms of the other thing is out of pocket expenditure, okay? So there is some variability in so the beverage system, as you can see, Brazil, Costa Rica, and Cuba, they have low levels of out of pocket expenditure. So basically, this is what you will pay for medicines or what you pay for the copay. So that's relatively low. And in the where there are implicit in the Bismarckian cases, you will see that there are higher levels of out-of-pocket expenditure. I don't seem to. There is a yes. We have here I'm not sure at the moment. I don't know if we don't do it or I just don't remember it. Whether I will imagine that those that they are in the non-contributory system have a higher out-of-pocket expense, but I am not. I don't remember now how to say. So the key patterns are in Beveridge kind of system. What you will see is consistently lower out-of-pocket expenditures, which is what I show you. But there's more variation in the Bismarckian system, and in the partial integration where you can opt out or not, there is a bit more out-of-pocket expense than in the others. So here we do the exercise that Nora was asking. So what we see is that when we try to decompose using the methods that you have seen, this Oaxaca type of decompositions that hopefully you were exposed during these talks or in general during these masters. Maternal and child health are largely explained by socioeconomic factor, and there is a very small unexplained component. When we go to adult preventive care, there is a larger unexplained component and significant system-based disparity, okay? Particularly in terms of treatment. So this points out that this fragmentation between contributory and non-contributory, of course, the poorer are in the non-contributory system, is a factor that contributes towards inequality in health outcome for non-communicable disease. Why, despite of that, the differences are smaller between non-communicable disease and maternal and child health? We can, we can speculate, but given that I have 1 minute, I will not. So, I mean, overall, just to give you some policy implications that we think are important, there are, 6 key areas for intervention, which is, I mean, kind of attacking the region has done very, very well in terms of making access to healthcare right, and it's written in most of the constitutions, but there is still high levels of fragmentation in the system because of this division between contributory and non-contributory and the high levels of informality. We have to find a way of getting around this, and I think that this is likely to improve overall health outcomes and reduce inequality. There are other obvious things that can be done because access to healthcare is not the only explaining factor. There can be health promotion programs. There is taxation for, Mexico has tried to tax the consumption of sugar, of sugary drinks and other foods that contain sugar, and many other countries in the region have followed suit. We know that improving housing and infrastructure mostly can help in terms of many outcomes in early childhood. There is a lot of really good causal evidence for that. And of course, a stable and good job is likely to lead to less stress, better mental health, etc. We are really behind in terms of providing good mental health services. This is just a growing need in the region, as well as elsewhere in the world. But the region is kind of lagging behind in that. And as you've seen from here, we did the best we could to find all the data that we wanted, and still we didn't get much data, particularly in adult life. So, I mean, countries need to invest in collecting data, and we need to, use multilateral organizations to harmonize these measures so that we know whether we are falling behind, whether we are improving, what are the ailments of our population. Okay. So I think that, I am right on time. This just repeats the main takeaways from what I said before. So I better stop here and take some more questions if there are. And you can access these two, I don't know, Nora will know this better. At some point they will appear in Oxford Open Economics, but the working papers are there. You have the versions of the IDB. And again, I want to thank my co-authors, Maria Fernanda, Antonella, Giancarlo, and Dolores and Marcos, which I learned quite a lot from working with them. So I don't know if there are questions you want to read them, Nora, or.
Actually, thank you very much, Samuel, for this fantastic overview of both health inequalities and inequality or characteristics of the health systems and how they may be contributing to the observed inequalities. I think that overall one could say that there seems to be a pretty much correlation, except maybe for Cuba, which I don't know how you classified the wealth levels in Cuba in between low health outcomes and being part of the poorest group defined by the characteristics that you use, either wealth or education. That's pretty systematic, right? And it's more striking, I think, in the places where you have large indigenous populations. So probably a lot has to do with indigenous/rural populations that are not exposed to the use of maybe not, they don't have access, or maybe there's differences also in terms of their socioeconomic level. Probably a combination of both. I mean, as a summary, as a summing up of what.
I think that, so for example, the region does very bad in terms of maternal mortality in many countries, but these are very few deaths that are very localized in rural areas with poor access, which will be relatively easy to target and solve. I think that we are just we are still farther away from the new from the 2030 development goals in terms of maternal mortality, and it's just
Right.
lack of access is an issue in many rural areas still.
Yeah, and that, that's one striking case is Mexico, which shows a lot of inequality in that dimension. It shouldn't. In any event, I think Ludovico, we have some questions here. I mean, Ludovico handles the Q&A and questions from the students. There's one on the Q&A.
Yes, we have one. How have government policies on universal health care and social protection influenced health inequalities in Latin America?
Yeah, I mean, as I said, there are, this work is kind of heroic in a way, no? I mean, it's descriptive of the overall system. Then there are some sort of, you try to find some sort of narrative, and then there are some papers that try to tease causal effect from particular set of policies, okay? So there is, there are a set of papers that have looked at this, at the benefits of the universal health system. I am blanking at this point in the results. On the results of them, there are for Mexico. Gabriela Conti and I think that Rita Ginja had those papers. I can look up them and then pass it to Ludovico if people are interested. So there are they look at that. Then I think that Marcos has a paper in terms of Marcos Vera has a paper with Grant Millen in terms of what happened in Colombia when they moved to this new system where there was coverage for the non-contributory system, and they see improvements in prevention. I remember, if I remember well. So there are some case. I said there are some case studies of well-identified examples of improvements either in prevention or in health outcome following, a better integration of the health system and an improvement in access. As you will expect, these papers are cited in the two papers I pointed out there in the in these review papers we prepare for the network.
We have a second question. If most countries in Latin America have a Bismarck system with formal employment or receiving a contributory pension, yet many individuals are informally employed, what is the best approach to healthcare systems moving forward? What other countries or models can policymakers look to?
Yeah, so that's a that's a big question that I don't know whether you have been discussing this or it's coming into the discussion. Most of our social security system is based on employment, on formal employment, okay, and between 10 and 50% of our population is not employed. So that raises the issue of how you give social protections to those that are not in formal employment. The Colombian case, I think that they integrate, I think that I like the fact that the benefits are explicit. And I think that whatever is the way you want to finance this and whatever is the way you decide to do this, you have to set a set of explicit benefits and made people member of different networks of care rather than the implicit mechanism where you go to the public hospital because you don't have an alternative. So I think that this is it's easier to put incentives to the providers, and it's easier to make people aware of what sort of benefits they have available and to manage the resource list more rationally. So I think that is a first thing I will suggest in countries where there is not an explicit package of coverage for those that are not in the non-contributory system.
Thank you, Samuel. If I may, I'd like to point out how incredible the paradox you noted is that there is falling fertility, but constant teenage pregnancy rates.
Yeah.
Particularly since you would think that the one policy approach that solves one would also be effective with the other, right? It's usually female empowerment that is what reduces fertility rates and education, but it seems not to affect teenage pregnancies.
No, I think it's one of the biggest research questions for Latin America. How can we move to fertility rates, many places below replacement? So we are below 2, okay? And still we have high rates of teenage pregnancy.
Yeah.
It's just,
Mind-boggling.
I don't have a great explanation for this. So I think that is a really, really important area of research, because there will be in terms of our societies will change a lot if women will have children later on in many, I think in many positive dimensions.
I wonder if you can tell us anything about the relationship between spending and health outcomes. I saw that there was significant variation across countries in the region.
There is usually a positive association between the two, but it's a little bit fuzzy, just because, you know, older countries that have older populations have also more income per capita, so they tend to spend more on health, but they also, you know, they're also older, so they need to spend more on health because they have all these non-communicable disease and all these things. So I don't think that the causation, we thought that we will find some sort of causation there, but it was not, I mean, causation, some sort of stronger associations. But I think that we are, you know, it's not so clear as far as I remember from the paper. I mean, whether there are any, you know, I mean, there is, I mean, we know from there are the typical cases. So the UK spends a lot less per capita in health and has better outcomes than other countries that we will not be named and spend a lot per capita on, you know, on health.
Is there anything we should know about life expectancy?
Why has it, what do you mean in terms of how it's measured?
Yes,
In terms
no,
of
trends and whether there are any obvious relationships to inequality that you've measured?
not in this paper.
Okay.
Not in this paper.
Okay. Nora, any other thoughts?
Oh, it's a lot of thoughts, but you know, we only have 2 minutes, so you know. But I mean, in terms of the teenage pregnancy and low fertility, means that, well, I don't know if you have data to track whether you have women who have one child when they're teenagers, but have much fewer children afterwards compared to before, and that would square the circle, right?
Yeah. So my sense on this is, so you know this well. One of the biggest problems in Latin America, which I hope that the LACIR network will push for, is that we don't have very good panel data. So so it's hard to do this. Okay, there is no country with a stable panel data set of 30 years. But one thing that we observe in the data is that there is this intergenerational transmission of having kids, you know, as a teenage, and then your kids also have kids as a teenage. So whether, of course, I don't know the channels of this, whether this is because they, you know, you educated them less or etc. There can be a lot of channels for this, but there is some sort of intergenerational transmission in the when you have children. Why this hasn't stopped, given that fertility rates had stopped, again, it's part of the, I don't have the explanation for that. I wish I had an explanation.
No, because I think it would be interesting to see if it's different people who have
No, but I think that fertility rates have fallen across the board. Rich and poor people, affluence level have not. Everybody has fallen fertility. If anything, yeah.
But teenage pregnancy, for example, is probably much higher among indigenous population because it's considered probably to be more
Sure. But the rates that we have in the region are not explained by indigenous population. It's just across the board.
So what might be interesting is you may have access to some sort of simulation models to see what you know, if you don't have panel data, what would it have to look like in order to produce the outcome that you observe, and then, you know, maybe you can have ways of testing this.
I agree. This is the one area where you just need some good structural model to try to tease out why, you know, what is the driving force in this. Anyway,
so I think we are out of time. And now we probably, well, thank you for the students. I think their Q&A, they've been responded, right?
Yes, they have.
We can move to the backstage.